Hello, my name is Jodie Dionne, and I'm pleased to be here with you today to discuss our work for the IDSOG conference titled Secondary Infertility and Bacterial Sexually Transmitted Infections in Cameroon, Africa. This work was done by the Cameroon Health Initiative team and led by Clarice Ngawi, who is a graduate student at the University of Buea in Cameroon. As introduction, secondary infertility is defined as the inability to conceive despite trying for at least 12 months in a couple that has a history of successful pregnancy carried to term. We know from decades of research that genital chlamydia and gonorrhea infection women can ascend to the upper tract and lead to tubal factor infertility. We also know from scant studies that rates of infertility in Cameroon are as high as 28%. This is consistently cited by couples as a major health priority across Africa. Causes of infertility in Africa are not well documented. The medical evaluation of infertility tends to be less extensive than what we do in the US. And STI management is syndromic, as recommended by the World Health Organization, which obviously leaves a lot of opportunities that are missed for testing and treatment. The study aim here was to document whether or not there was an association between secondary infertility and bacterial STI for chlamydia, gonorrhea, and mycoplasma, with the hypothesis that if there's infection present, this may be a reversible cause of secondary infertility for some women. So for methods, women were selected from Cameroon between the ages of 18 and 45. Cases were defined as women seeking medical evaluation for secondary infertility, and controls were randomly selected pregnant women seen for routine prenatal care in OBGYN clinics. There was approximately a 1-to-2 match of cases and controls, and the only exclusion criteria, other than what I've mentioned, was antibiotics within the past 7 days. All women provided informed consent, and they completed a survey of clinical and behavioral characteristics at the time of swab collection. The endocervical swabs were collected by their provider and for NAT testing, which was performed at the UAB Diagnostic STI Laboratory. We looked for chlamydia trachomatis, Neisseria gonorrhea using the Aptima Combo 2 test, and mycoplasma genitalium using the SpeedX test. Our major analytic method was to use logistic regression to evaluate the association between these bacterial STI and secondary infertility. And these are our results. You can see listed here on table 1 is a comparison of the characteristics for the 150 cases with infertility and 242 pregnant controls. And the cases on average were slightly older, 31.6 years compared to 27.8. They had a higher proportion of women with greater than 5 lifetime sex partners. If you notice in the parity row, the average parity in Cameroon is 5.5. So both of these groups have a high number of pregnancies in the past. More women in the cases reporting a history of chlamydia, 29% compared to 0, and a history of miscarriage and ectopic pregnancy. So for the major study outcome, we overall found rates of CT, GC, and MG ranging 1.3 to 3.3% in the cases and 1.2 to 5.4% in the controls. And on average, these rates were slightly higher in controls compared to cases, although the differences were not statistically significant. In our model, you can see the crude model on the left, age, higher number of lifetime sex partners, history of miscarriage and ectopic pregnancy were associated with infertility, but GCCT infection, mycoplasma infection as a composite outcome was not associated. And in an adjusted model that adjusted for age and higher number of lifetime partners, GCCT mycoplasma was still not associated with the outcome. So in conclusion, the prevalence of GCCT mycoplasma in women in Cameroon with infertility was quite low, ranging from 1.3% to 3.3%. We did not see an association between the prevalence of these STIs and secondary infertility in women, although women with secondary infertility had much higher rates of self-reported history of chlamydia and adverse birth outcomes in the past, specifically miscarriage and ectopic pregnancy. The next steps that we're going to do is look at serologies on these women that we have stored. We're going to look for IgG and IgG subtypes to look for a difference in the presence of IgG indicating prior exposure, which we suspect is going to be higher in the cases compared to the controls. I'd like to thank you for your attention.